Hi everyone, thank you for joining us today. So we're here as part of the Health and Wellbeing Alliance webinar. So we're going to be talking about how we can ensure social prescribing is inclusive. So thank you very much for everyone for joining us today. I know it's a bit of an odd one for everyone, but I'll just do a quick introduction and talk through who will be joining us today. So we are having a bit of a technical difficulty at the moment with one of our attendees, so we might have to rejig this a bit at the moment. But my name is Catherine Goodall. And I'm a Senior Policy Officer for Public Services at NCVO. So we're the National Council for Voluntary Organisations. So we're an umbrella body for the children's, for the voluntary and community sector. So we've got about 15,000 members. And we'll be hearing from, hopefully, will be joining us, so Rebecca Big from Live Well Wakefield, from colleagues Jo Crease from Together Co, from Dawn Mitchell at Street Games, and from Dan Jones at National Voices. And I've got some support from colleagues as well on the technical side of this today. So today's webinar, so we'll very quickly talk briefly about social prescribing. So we know there's an awful lot of webinars out there, a lot of information out there about social prescribing. So we're not going to go into a lot of detail about the background of that, as we'll signpost to information later. But we're really going to focus about the possibilities and the potential of social prescribing to tackle inequality and exclusion. We'll talk through some examples of inclusive social prescribing models. We'll hear from colleagues about their work and how we're all working to make social prescribing inclusive. And we'll look at opportunities and challenges to making the NHS expansion of social prescribing inclusive. So in terms of the timings, it's a really tight set of timings today. So we'll have some quick introductions. I'll be talking a little bit about inequalities and health inequalities. We are planning to hear from Rebecca, so hopefully she'll be able to join us. And then from Jo, Dawn and Dan. And then we'll hopefully have some time for questions and answers at the end. Do please feel free to add questions and answers into the chat, and we'll hopefully pick those up later for you. So why are we here today? So the Health and Wellbeing Alliance, I'll just quickly talk through that in case you're not aware, but NCVO is part of a partnership between the voluntary sector and the health and care system. So there are 21 different charities and voluntary organisations that are part of this. And the aim of the Alliance is to improve integrated working and communication between communities, the voluntary sector and the NHS. So we're really aiming to amplify the voice of the voluntary sector and people with lived experiences to inform national policy. We're looking to co-produce solutions to promote equality and reduce health inequalities. So that's why we're here today. So we're not only just sort of sharing our learning and our knowledge with you, but we're also really interested in hearing from you and hearing some of your key questions, and hopefully we can provide some answers for that today. So why are we here in terms of inclusion and health inequalities? What do we mean by that? So we know that many people experience inequalities in their life outcomes and their health and social care support that they receive. So there are a wide range of factors for that affecting inequalities, such as where people live, how their services respond to their age, perhaps, or their race or their gender. And we know that social prescribing can help address those inequalities. Sorry, bear with me 1 second. Sorry, there was a bit of a technical issue there. So we know that there are a lot of different health inequalities out there. I don't know if you saw recently, there was the Health Equity Report. So 10 years on from the Marmot Review was recently published, and that looks at the significant differences in healthy living and life expectancy between different groups of people across the country. I'd really recommend checking that out if you haven't had a chance to see it so far. But we know that depending on where you live in the country, depending on what your different characteristics and your background are, you will experience different inequalities in your outcomes in the health and the social care that you receive. And we know that social prescribing can help address these inequalities, but only if it's implemented well. So that's really why we're here today, to think through the different ways that social prescribing can deal with these inequalities. So as I said, we're not going to go into a lot of depth about social prescribing, but I always think it's helpful to have a bit of a quick introduction. So we know that social prescribing acknowledges that our needs are much broader than just our healthcare. So there's lots of different ways that social prescribing has existed in many different forms across this country and others. But the NHS definition is that social prescribing enables general practitioners, nurses and other primary care professionals to refer people to a range of local and non-clinical services. So that could be anything from a local walking group, a choir, a youth group or a knitting club, for example. And as part of the NHS programme we'll be talking about in a bit more detail, link workers support a person so they understand their needs and they'll try to find different forms of local support and make connections for them. So in terms of the NHS social prescribing expansion, there are primary care networks. So you might have heard a lot about primary care networks. We won't go into a lot of detail now, but their aim is to draw together different primary care services in an area, encouraging personalised and integrated health and social care. And they're for populations of around 30 to 50,000 people. And it's these primary care networks, or PCMs, that are aiming to employ 1,000 social prescribing link workers by 2021. And aiming to refer 900,000 people through social prescribing by 23-24. So it's quite large numbers of people we're talking about. And as part of that programme as well, there's been a National Social Prescribing Academy, which has been established. And they published a new strategy and some documents last week. So it's really worth checking out if you want to know a bit more about the sort of national evidence gathering and promotion of social prescribing. And we know there are widespread concerns across the sector about quality of social prescribing, the possibility of duplicating existing voluntary work. So hearing from our colleagues today about all the different types of social prescribing that's underway. We know there are concerns around lack of funding for referrals and particularly that social prescribing might not be inclusive for everyone. So it's really why we're here today, to talk through different existing pieces of work and how we can really take the lessons from that to make sure the social prescribing we're engaged with meets individual people's needs and reduces inequalities. So I'm going to pass on to our colleague Rebecca. So Rebecca, if you're ready, I'm going to change presenter to you. So hi Rebecca.
Hi, can you hear me?
We can, yes, hi.
So if I just do the slideshow from my laptop, is that?
Yes, yeah, sorry about that, yeah.
Okay, so yeah, so my name is Rebecca Bibbs. I'm the Live Well Wakefield Service Manager. So Live Well is actually commissioned by the local authority in Wakefield through Public Health, and then we are delivered in a partnership so between Nova, which is a third sector infrastructure organisation, and South West Yorkshire NHS Foundation Trust. We were commissioned in April 2017 and have been running since then. And last year in July 2019, we worked with our primary care networks to start providing link workers into those networks as well. So these are our only criteria for referral. So people need to be over 18 and either live in the Wakefield area or be registered with a GP in Wakefield. As our criteria is obviously quite wide, then we feel that that gives people, as long as they're an adult, access to our service, irrespective of whereabouts in the district that they live, the age that they are, any other factors really. So it doesn't matter what their need is, what their ethnic background is, whether they're employed or not. Literally, that is our only criteria. They can also be referred by any professional, so it doesn't have to be somebody in primary care or anything like that. It can be absolutely anybody, and they can also self-refer as well. We help people with anything that would affect their health and well-being that isn't a medical need. So things like benefits and finance, employment, training, bereavement, aids and adaptations to their homes, independent living, social isolation, anything like that. And they can be referred or refer themselves by telephone, email, our website, we've got an e-referral from System 1 for primary care staff, and we even get referrals via social media as well. So we use a social prescribing tool, initial assessment, that we actually developed ourselves and is endorsed by NICE. I can send the link out if anybody wants to have a look at it. It is in the public domain. So we go out to usually someone's home, or they can be seen at a GP surgery or community setting. We carry out the initial assessment that's based on the 5 ways to wellbeing. So it covers everything from whether they can get out and about enough to see family and friends, to whether they can pay their gas and electricity bills, things like that. At the end of the initial assessment, we devise a personalised care plan. So we agree with the person what's important to them, what matters to them, what out of the things we've discussed that day might be a priority for them, what would really make a difference to their life. And at the end of that initial assessment, that plan will be agreed, and there'll be some things that the advisor or the link worker will go away and do, so such as onward referrals or gathering information about local groups. And also, if that person is able to self-care, we might ask them to do some things as well. If they're able to find out about local groups or pop along themselves or things like that, then we'll encourage self-care wherever we can as well. We also follow up at 6 weeks, 6 months and 12 months. So that has led us to receive most of our referrals as self-referrals. That's mostly by sort of word of mouth or advertising on social media, putting leaflets out there, anything we can really. And then that's closely followed by referrals from primary care, and then social care direct, which is Wakefield's sort of triage system for social care calls. That is changing slightly at the moment because we've just recruited and implemented link workers in primary care networks. Then we are seeing more referrals from GPs now, but we still have a really healthy chunk of referrals from self-referrals as well. So we also have seen that 75% of the people that we see are new people. So 25% have seen us before, but 75% are new referrals. We see referrals from all over the district, and 25% of our referrals are from the most deprived areas in Wakefield. So we feel that that is sort of good evidence to show that we're reaching the people that really need it. In terms of age ranges, so as I said before, we only accept referrals that are 18 plus, but we do get quite a big spread over the age ranges. Most people that we see are over 55, but as you can see from the graph, there is a spread amongst all age ranges, and we see about 57% women, 43% men. So there is still a bit of a gap there, but compared to a lot of other services, it's probably you know, quite normal really. 9 out of 10 people that we see show an improvement. So the social prescribing tool that I talked about earlier can be used to set a baseline score in wellbeing, and then when we review that at 6 weeks, 6 months and 12 months, we see that 9 out of 10 people show improvements, and then the graph on the bottom there is just the average improvement from initial to 12 months. 98% of our clients said that they would recommend us to family or friends. So again, that's really good for us. So I just wanted to also talk a little bit about sort of onward referrals and signposting as well. So we have directories, which again, if you Googled, you can find them in the public domain. We have directories organised into villages in Wakefield that people can relate to and find more local. And they cover everything from knit and natters to coffee mornings to lunch clubs, food banks, anything you can think of that's available in the local community. We update them all the time, but we do a big update once every 6 months as well. And up to now, we have never tried to control what's in those directories or quality assure what's in those directories. So we give people the information. We know a lot of the organisers of these groups. So if someone new is going to go along, then we will ring that group and tell them to, to watch out for that person, or to make them a cup of tea when they get there, to make them feel welcome. But we don't necessarily quality assure all the groups, and that is because we feel that to give a truly tailored, personalised plan to somebody means that we can't just cut down the amount of things that we refer to almost a menu. We feel that that's too restrictive, and means that it's not personalised to that person, because they might be interested in or want to find out more about things that aren't on a smaller menu. So if you do Google the directories, they contain hundreds, if not thousands, of local smaller groups. We also have a small grants fund as well. So this is just showing the first 3 rounds that we have. So while we are signposting or referring people out to these smaller groups in their community, we realise that that isn't free, and that if we're sending more people their way, they can reach capacity, or need more investment to extend what they're doing. So we do have a pot of funding that again is provided by public health at the local authority, and people can apply to that funding. It's only available to third sector organisations, and it's for anything that is either a new group that we could use to refer people onto, or to build capacity where we have sent lots of people and capacity is becoming an issue. That's it from me.
Thank you so much. So we did have a couple of questions that came up. So one person had asked, how come the referral form only refers to disabled people with age-related conditions? I don't know if you've got an answer to that.
Our referral.
Yeah, I think it was on one of the slides that you'd shared.
Oh, that's not a referral form, sorry, that is just, I'll go back to it. That is just a screenshot of our, let me just have a look from current slide. That is just a screenshot of our initial assessment tool, and that bit on the front had to be added to get the nice endorsement. So often we hold a lot more information about that person, but that's just the front cover of the initial assessment. That's not a referral form.
Brilliant, thank you. I think that's really helpful. I think someone else has asked, how do you ensure confidentiality of referrals, particularly via social media?
Yeah, so we would, on social media, we would literally just ask the person if we could contact them by telephone to gather their information, or if they could email to our secure email address. Obviously, again, only if they have a secure email, or what we'll do is we'll phone them. We find that some people just don't like to make that first contact. They're a little bit anxious, a little bit nervous, and they don't like making the first contact. So even if we can just get an email address or a telephone number, and then we'll ring and get the rest of the personal information.
Brilliant. Fantastic. So I think we're picking up quite a few questions, but I think we'll come back to, in the interest of time, so we've got everyone to a chance to speak. I think we'll pick those up later if that's okay.
Yeah, that's fine by me.
Thank you so much. Do you want to pass the presenter back over?
How do I do that?
Oh, brilliant. So there we are. So I'm going to pass over now to our colleague Jo.
Oh, hello, can you hear me?
Hi, Jo, sorry.
Hi. I think you've got the presentation there.
Oh, okay, yeah, sorry. So
it's in your pack, isn't it, Catherine?
Yes, sorry. So bear with me one second. So I thought we were passing over to you for you to share your screen. Bear with me.
It wasn't any help at all. It was unique. Do you know how I just feel like when we were dialing through. I did actually. I did register. Yeah. So I shouldn't have to see it. Yeah. So it was on listen only. I don't know.
Sorry, bear with me one second.
Maybe she's having problems too. But yeah, well done. That went very cool at prices. Let's click on that, yes.
All right,
Sorry,
so
Joe. Yeah.
that's all right.
There we are.
Hello, hi everybody. Hi, I'm Jo Crease, for the Chief Exec of Together Co. We are a loneliness charity in Brighton and Hove. We run befriending and social prescribing and volunteering and a range of other support activities for people. Sorry, Catherine, how do I move this on? Oh, there we go.
I see, because
So,
I think I have to control it, I'm afraid. So
oh, I see. Right, sorry. I'll give you a virtual nod when it's time. Yeah. So, a bit about our social prescribing service. I won't go into too much detail because obviously there are similarities with what Rebecca was talking about. But we've been going for six or so years. We started off very, very small as part of a health systems improvement piece of work funded by the PM Challenge Fund back in 2014. We were supported really strongly by the CCG from the beginning, in particular our officer that leads on patient and public involvement and third sector preventative kind of stuff. We started quite small. Surgeries were very much self-selecting in that first instance, so GPs that had an interest in this kind of thing, that worked quite well because everybody was very keen. We developed the service literally from scratch, based on the kind of knowledge that was out there at the time and what would work in Brighton and Hove. So it's been very much kind of co-developed over the years with clients and volunteers and staff and GPs and clinicians and others working in health and voluntary sector partners as well. We've now got 5 paid social prescribing link workers and a manager. We've got around 14 volunteers in various support roles at the moment, and those roles have evolved over the years as well. We've got 5 new PCN funded link workers starting next week, which is going to be really interesting in inducting people when we are going to be working at home from tomorrow. So we're testing out all kinds of technology, which is really exciting actually to do that. We've just launched on Social Prescribing Day last week our self-referrals method via a social prescribing hub. Previously, it's been referrals from primary care only or from adult social care and from partner organisations, but now we've opened it out much more widely, and it's the PCN resource that's enabling us to do that, because that essentially frees up the kind of citywide social prescribing service that's been funded by the CCG for the last few years to a wider audience. Our team are enormously experienced. Most of them have been with us since the beginning or very much close to the beginning. They are all previously advocates, caseworkers, social workers, and I think it's quite useful to reflect that these are the professions and skills that really are most akin to link work in lots of ways, because of the focus on understanding folks, listening to folks, using those kinds of techniques around active listening and so on to help empower people to make changes and make take up activities and so on. The PCN work is really positive locally. I'll talk a bit more about that later. The last little bit over the right hand side there shows a bit about our growth, and really the increase in referrals is phenomenal at this point, and although very quiet at the moment because of everything else that's going on with COVID-19. So thanks, Catherine. If you could move on for me. A little bit more about how we work. We're also a holistic social prescribing service. We're very person-centred. We offer 3 to 6 sessions for people. Sometimes it ends up being more than that, and sometimes people will come back into the system again. And I think in the last few months, the average has been 3 sessions, and with follow-up at 3 months and further on after that. The social prescribing generally takes place in the place of a client's choice, so it might be their home or it might be a cafe or community venue that they are comfortable in, sometimes in surgeries, but they're obviously very pressed for space, so it tends to be more community based. We've had volunteers from the beginning. That's fine, right? Okay, so a bit about the reasons for social prescribing. I've noticed this is a good way, Catherine, of you keeping me moving and not dwelling too long, so well done. No, that's grand. So I wanted to put this slide in because this is a really important thing around accessibility. The highest reasons for referral are social isolation, mental health, benefits advice and information advice and guidance, and most people who come through the service have at least one, if not more, of the top 4 reasons, plus at least one other issue. There's a whole load of issues and referral reasons beyond 16%, but this is sort of the top number. And as you can see, this only refers to certain types of referrals, but it gives a really good sense of the shape of the graph. And the picture is very much the same when we do include all referrals to partner organisations and from adult social care and so on. We define a complex case as a place, sorry, just to finish on the previous one. A complex case is where a client has 3 or more factors, and we have seen a really big increase in the number and the proportion of complex cases since we started. It was about 6% when we began in 2014, and it's around 20% now. And so for us as a service, we need to be really clear about where the boundaries are with things like social work, casework and so on, and where our work needs to sort of sit next to and in line with other statutory support. And that becomes quite difficult where there are gaps in provision, and we see that mostly and most sharply in mental health services locally, particularly secondary mental health. I talked a bit about the increase in referrals, and how we kind of are managing that at the moment is to be really clear with referrers about what those referral criteria are. And unlike Rebecca, we do have some referral criteria, mostly because we had started with a very small team and were quite essentially volunteer supported. So it's important to make sure that we don't take on things that really aren't really shouldn't be done by us. They should be dealt with by casework or mental health services or whatever. We can take certain more advanced situations, so where people do have mental health issues, as long as those are kind of diagnosed and understood and managed, then social prescribing can really be a helpful part of a package for people. And similarly with dementia, where people have early stage dementia and we're already engaged with them, that can be a really useful part of support for them. And later on, when dementia is more advanced, if we're engaged with family, that can actually be a really useful way of supporting the family. But there are obviously can be challenges with the client. One of the things that I wanted to mention, which will come up later on, is that the relationship between the link worker and the client is really at the heart of this, and that's very much the same with whoever is delivering. So Social Prescribing Plus is kind of an extension, if you like, of the inverted commas mainstream social prescribing service. So we work with our specialist delivery partners, who you can see their logos on the right there. So those are local voluntary organisations that we work with in a number of ways, and in particular here on the Social Prescribing Plus project. So this is to make sure the aim of the piece of work funded by the Health and Wellbeing Fund from the Department of Health and Social Care from 2018 was around ensuring social prescribing is accessible for folks who have greater health inequalities, greater barriers to accessing mainstream services. The way that works is that the link worker is based within the partner organisations and employed by them, but they're very much part of our team. So they come to our team meetings, they come to our case review meetings, they get the same peer support and clinical support as our staff internally. There's a very strong kind of cross-organisational team there, and we talk with people when they get referred about where they want to have the social prescribing take place, and if they have a preference, we make sure that happens there. We invested really heavily in terms of time from the beginning with good partnership working in terms of governance and communication methods, and the way we set the team up, the finances and planning and so on. So it really is a very strong partnership that we are hopefully building on. Okay, so the next one is a little bit about what we found from the Social Prescribing Plus work, in sense of working with those particular groups. And what we find is that a lot of the same issues primarily will come up, and that chart I showed before with the reasons for referral, they tend to be quite similar, but they tend also to be more in depth, require more time and more support, and this is what you would expect. And for community organisations, they will tell you that this is a very familiar kind of story. We found also that a really key thing in making it work for people is that there is a familiar organisation, there's a trusted organisation, and we build on existing relationship. So where an organisation is already engaged with an individual, it's much more likely to be a successful and sustainable social prescribing referral and outcome than if we ask them to start again from the beginning with someone that they don't know. Again, really common sense stuff. So my strong view and our findings show that the approach really works by doing it alongside other support, and to make sure that the delivery organisations can be diverse and rooted in communities. Okay, next one. So enabling accessibility, this is a little bit about the structure of the way social prescribing is being set up and resourced, in particular through NHS England at the moment. We need to be really clear that this is about social prescribing and getting people to the activities and support that they need, not necessarily, in our case, definitely mostly not provision of the activities themselves. We're really lucky in Brighton and Hove that we have a really thriving and strong voluntary sector. We actually have 2,336 voluntary and community organisations in our city. So obviously a GP can't possibly know which one of those is the right one to refer to, and that's really where we come in. But there's also a real sense that rich sort of source of opportunities for people needs to be very carefully kind of nurtured and looked after. There's a real issue at the moment with the NHS England funding. The DES is the GP new contract, and it pushes the risk right down to the smallest organisation in the supply chain. So we're providing, for example, link workers for PCNs. We have to claim their salaries in arrears, and then they have to claim that money from the CCG, who claim it from NHS England, and there's a chance that that may well be delayed, and we're carrying the financial risk potentially there. And that is something that would exclude smaller organisations, perhaps particularly specialist organisations, from being involved in social prescribing, and that would therefore be a barrier to enhancing accessibility. There's also a point at the bottom there about the performance measures based on numbers does not really relate to quality and accessibility, especially where we've illustrated earlier that a good outcome requires more time. Okay, next one is around some practical delivery challenges as regards to the workforce needs. There are huge challenges regarding the link worker workforce, and even the simplest link work cases can be really challenging, or they can become challenging. And I think that link workers need a much more sort of sophisticated set of training in the range of specialist skills, and I've listed a few of them there. And they need the structure in order to be able to do the job that they are being brought in to do. They need this kind of structure around case management, line management, clinical supervision, all of those kinds of things, as well as the practical resources. And I know of people, not in Brighton and Hove, but relatively locally, who've come into post as a solo link worker and have had none of that and have left already. And that's a real shame. And waste of good people, basically. So in order to support that, we also run a social prescribing practitioner and network provider networks, one of each, where we share expertise, intelligence, and connect people together. So next one, just winding up now, opportunities. Social prescribing is a really, really valuable part of tackling health inequalities. And there's a huge potential for social prescribing to really grow. But it relies on really genuine equal co-working between clinicians and social prescribing link workers and services. And people really want to do that, but it feels at the moment like some of the systems can be a barrier to that. It's not the only thing that can tackle health inequalities, but it is obviously part of a picture. There are some really innovative PCNs who are doing what they've wanted to do for a long time, which is to embrace the community, to embrace voluntary and community sector provision, and to bring in that wisdom and that experience from us in the sector to offer a much more wider and more kind of whole person approach to health and wellbeing. And there's also examples in Brighton and Hove where, for example, individual patients and community groups are being involved in the development of PCNs. So we've got a health forum, which is a group of PPGs, patient participation groups, and there's a rep from that group who is on one of our PCN boards, and they also have a voluntary sector rep on that board. It's really important to build the diversity of provision, and if you've got diversity of provision, rather, to build it into an integrated system so we don't end up with reduplication and people getting handed off between organisations. We feel in Brighton that we've got a really strong sector and really strong relationships with our local statutory organisations, and we're working really hard with them on how we can build a sensible integrated system. And obviously the point that has been made before about investment in the voluntary and community sector, community activities, and also other statutory activities and support where that's necessary. And it's a good chance for us to demonstrate the impact of community-based preventative work and hopefully make the case that funding should follow that. And finally, just to summarise, Catherine, if you could flip on, thank you. So my summary is about that really for everybody, regardless of who you are or what your kind of characteristics are, the relationship with a link worker is at the heart of it all, and people would do well to make most of existing organisations and partners. The delivery really needs to be rooted in communities, and the funding should be enabling this rather than risking it, and that the link worker role needs support and structure, and that PCNs are already involving and learning from communities, and that I'm looking forward to more of that. And my final one is just to say thank you, and I'll be really happy to hear from people about our work and how we might help you.
Thank you so much, Jo. That is fantastic. We do have a few questions, but I think in the interest of time, if we could come back to those in the Q&A for you, that might be best. If that's all right?
Sure. Thank you.
Perfect. Thank you so much. So I'm going to pass on now to Dawn, if you're ready for us, Dawn. Sorry, bear with us as it switches over.
Yeah, I've got it. You should be able to see my screen now.
Yes, yeah.
Fantastic. Morning, everyone. So my name's Dawn Mitchell. I'm the programme lead for Young People Social Prescribing within Street Games. I would give all credit to the development of this work to Paul Jarvis Beasley, who some of you might recognise that name, who's the head of health, but I've fairly recently stepped up to be programme lead. A couple of things just in terms of the number of people who are on this call. It's fantastic to see if anyone is interested in social prescribing for young people. We launched the Twitter page or the Twitter handle on Social Prescribing Week last week, so please do follow at Young People Social One. Find us there, and that's where we'll be sharing information. There's also my email address there. Please do get in touch if young people and social prescribing is something that you're interested in. My aim today is to share some of the learning from the 2-year research project that's been going on, and I will crack on and do that. I'll put my details up again at the end for people who are interested. So what we know is that in our communities, and looking at the 3 levels in which social prescribing can impact, we look at individuals, communities, and how services impact on that. Ideally, all these things are joined up in a nice cohesive way, but unfortunately we know that for a number of reasons this isn't always the case. Specifically focusing on the challenges for young people, we actually, when you think of social prescribing, it does have a big impact around loneliness, and actually the evidence says that our loneliest reporting group of people in our communities are young people aged 16 to 24. We also know that the additional inequalities that are impacting on some of our young people, obviously highlighted in this slide, which I'm sure a lot of you will be familiar with. And Street Games has a track record of working in the lower socioeconomic groups, so we really want to try and provide support and help for those young people in the lowest socioeconomic groups who maybe have less opportunity for connection. Just a couple of statistics. As we come on to our referral criteria, you'll see that this second statistic, 75% of lifetime mental health conditions present by the age of 18, is reflected in our referrals, and that a lot of young people that we're speaking to are talking to us about their challenges around mental health and wellbeing. Now, the great thing here, the really exciting bit of the research that, well, personally I'm excited about, is that we know that actually mental illness being present for an extended period of time before diagnosis can lead to worse outcomes. So if we're able to engage young people and get them talking about their challenges earlier and getting them not medicalised but supportive way, the social support that may help positively impact, then that's going to be potentially a game changer going forward. So as I said, ideally all of our services link up nicely. that isn't always the case, especially for our young people who are potentially more socially isolated or not in mainstream education, for example. So here comes our link worker to try and start putting some of these connections in place. What that looks like in terms of the process is that we are talking about social prescribing for children, young people and families going forwards. I think that's something that's important to look at. In terms of the research, so I should say the research project's been going for just over 2 years now, being funded by the Health and Wellbeing Fund and our research partners are the University of East London. And what we've been really focusing on is what are those key differences for social prescribing for young people as opposed to older or adults. And so, for example, nationally, the PCN link workers are funded as an all-age service, and that comes from NHS England and the personalised care team. But we're aware in some places, for example, the delivery partner may be Age UK. So there's challenges there about how is this service going to be accessible for our young people and relevant as well. So that's just a bit of background on the research, and obviously what I'm talking to you about today is information that we're drawing out of that research. So what we know is that link worker can be that point of contact from a number of different referrers. So something that the research is telling us is that there are some referrals from GPs in primary care, but generally that isn't where our young people show up. First of all, one of the surprising developments we found was actually from the police and crime commissioners, who've been a prominent referrer to these services. So where a young person is at risk of either having to be taken down a safeguarding route or a criminal justice route, actually social prescribing can be a positive intervention for that young person to not go down one of those alternatives. So we've had some really interesting learning there. And in the wider, more strategic approach, I guess the link worker has a vital role there, and that's maybe not the link worker per se, but the service managers. And where our services have been sitting, again, our link workers in our pilot areas, they haven't been sitting necessarily in traditional primary care settings. They've been based in community, voluntary community organisations that specialise with youth work. The evidence that's showing is that it's been more effective to have an experienced youth worker who is upskilled in social prescribing, as opposed to someone with a background of social prescribing upskilling into the link worker role. But I'm aware that because there's so many people in post already who maybe don't have that youth work background but have been tasked with doing youth work, that's a big, what I'd like to ask the group today is what training is available, or what training would you like to see, because part of my role is to develop training to support people in the specialism of youth social prescribing. So Street Games already has a number of options available, but I feel like there's maybe some gaps that we need to have a think about providing support for that. I'd be interested to hear thoughts. Some of the benefits that we're finding, this is multi-level, obviously for the individual. I think what's really important is the voice of the young people that we're getting to hear through the research. What our young people are saying is what they're finding most valuable is protected time with a trusted adult who doesn't have an agenda, who they don't have to repeat their story to 3, 4 or 5 times, who is a consistent kind of ally and someone who they build trust with. And then who they trust to introduce them to those opportunities in the community. In terms of the VCSE, again, to reiterate, I know I've heard some challenges from colleagues about where that funding comes from. We are talking to NHS England, and it's very small numbers, but about personal health budgets which can follow young or come with a young person through their journey into voluntary and community sector. Early days with that, but I think there's some interesting discussions to be had. Benefits for the referrer, knowing that they're sending a young person to a trusted individual, not taking them down a clinical route or a criminal justice route, knowing that actually there's a better intervention for this young person, and obviously commissioning outcomes and potential positive outcomes there. So this is just a little snapshot of what we're getting out of the data. So the average age 17 with a range of 11 to 24. Some of the considerations around that, obviously, we have been having a higher number than expected number of disclosures because of the relationship that link workers are building with young people. So we're trying to do a lot of learning around, it goes back to what colleagues were saying about making sure that link workers have the right knowledge, the right information, but also the right support themselves if they're dealing with a lot of disclosures from young people. So things like clinical supervision, making sure they know how to help look after themselves as well. Yeah, I just won't go through all of those in vast detail. Reasons for referral. So the primary reason being mental health and wellbeing, or low levels. So mild to moderate mental health and low levels of self-reported wellbeing. Obviously, through the research pilot, we've got a whole raft of tools that we're using. So we're using the outcome star, we're using WenWebs, we're using the ONS lifestyle questions, physical health conditions, and social isolation being the biggest ones. And then young people who are interested in making a lifestyle change but maybe feel unsure about how to do that. These are our partners. So the delivery partners, we have our YMCA Downs link, which are based in Brighton and Hove. Just to say a little bit about the different models. So the YMCA Downs link group run the whole of the young people's wellbeing services. So here they use social prescribing in two ways. First of all, as a step down. So where a young person's been accessing CAMS, they use it as a step down approach as they exit the service. So they don't just leave, they actually get a step down approach to help the young person go out into the community, feeling supported. But also where a young person might not meet the threshold for clinical services such as CAMS, that actually there is now an offer for those young people. No Limits Southampton, again an experienced youth work organisation who have been developing their offer as part of their wider projects. Sheffield Futures, interestingly in Sheffield now, Sheffield Futures have been approached off the back of the pilot work to host other link workers on behalf of the primary care networks, which has been fantastic. Active Luton also now are hosting not just young people social prescribing link workers, but also the adult link workers who are coming into post. And Enfield has a multi-partner approach. It's part funded by public health, part funded by local authority, and it's delivered by the voluntary community lead in that area. So lots of different models, and what we're really interested in is continuing the learning. So what we'd like to do is people who maybe are interested in joining this network, yes, sorry, that's just a summary of what I was saying about the different models. And what we see are a lot of opportunities, to keep learning, to learn from best practice and to share best practice. We've just been commissioned by NHS England to develop the national guidance for young people social prescribing. So if anyone is doing any work around young people social prescribing and they have things like case studies that they want to share that might then go on to be included in the national NHS recommendations and guidelines, please do get in touch. Lots of ways in which we want to continue to develop and learning from different models. So for example, I'm currently speaking to someone at a youth offending organisation where they want to use social prescribing as an exit route because the young people don't get any support as they leave at the minute. So rather than just being released, actually being released with a link worker attached to them to help them find support in the local communities. So any different kind of models, really keen to hear about. In terms of what it takes to get going, the model that we've looked at for each of our pilot sites is a part-time link worker, identified resource for management structure, the network of referrers, a comms activity budget. The activity budget is directly attached to a young person, maybe a pair of trainers, most commonly used for travel costs actually. Some training for the link workers and a basic level of monitoring and evaluation, which has been costed at about 50,000 per year. to join in with what we're doing, and we are, as I say, really keen to hear from people and get people involved, we've got a national specialist interest group, so you can follow us, as I say, on that Twitter handle. Drop me an email, get signed up. You'll be the first to hear about things like knowledge exchanges, which we'll be doing probably virtually when we launch the link worker guidelines. There's also the option of a project management group, which is additional support from either myself or field workers to actually help you get set up. And just to summarise, I hope that's been interesting for people. There's a real opportunity here for young people and making social prescribing work for them. And hopefully I'll hear from a few of you off the back of this. Thank you.
Thank you so much, Dawn. That's fantastic. We are having lots of questions, but in the interest of time, I think we'll pick those up afterwards. Dawn, if you wouldn't mind changing the presenter back to me. Fantastic. And I will pass on to Dan. We'll just wait for 1 second while it changes. Right.
Okay. Have you got me?
Yes, yeah.
Super. Hi, I'm Dan Jones from National Voices. We are the coalition of health and social care charities in England. Have more than 160 members, which includes kind of big national organisations that you'll have heard of, the condition-specific ones like British Heart or British Lung Foundation, but also HUK and the kind of other large national organisations, but also local patient groups and small organisations. And we've been commissioned by NHS England to gather insights and experience of the VCSE sector on social prescribing in the context of this big rollout that Catherine was talking about of PCN link workers, to help the NHS understand more about how it can work effectively with VCSE on social prescribing, and to identify solutions that can address some of the issues that other people have spoken about, but also that are raised by this new rollout. We're doing this because as health and care charities, we think that social prescribing is a real positive for the sector, primarily because it recognises that people aren't just about their interaction with the NHS, that even people with long-term health conditions have practical, emotional, social needs, and that's what matters to them. And as kind of promoters of personalised care and responses to what people need, social prescribing is a great way into getting the health system to think differently about that. It's also recognition that we in the sector are better placed to meet some of those needs than the NHS. We think that's a positive, and potentially, with all of the caveats that people already said, it is an opportunity to engage the statutory sector in a discussion about how the voluntary sector helps stronger communities. That obviously at the moment, that sense that community resilience is something we're all going to rely on is particularly low. And this is what we as a sector have done. So actually, this is a great opportunity for other parts of the statutory system to come to our table. And we see particularly real opportunities to develop better, stronger partnerships with the NHS. And now is the time to do that. So what we've done so far, we have interviewed about 50 people involved in social prescribing, and we've held face-to-face workshops in 3 regions, Newcastle, in North East, South West and Greater Manchester. So far we've heard from about 200 people. Luckily we did this a few weeks ago. And we've identified, I guess, kind of 8 big issues that seem to come out. 4 related to link worker rollout. So getting the role itself right, and obviously there were concerns around overheads. Those haven't gone away, but NHS England has moved on them. So originally the contract for link workers was designed essentially by a very internal bit of NHS England thinking about how it did contracts with GP practices, and it did not think about people who were not GP practices employing these people. So the kind of allowances for on costs and salary scales and things were not effectively. So there has been some movement on that, and it is now possible for employers of link workers as many of you know, had quite a lot of background noise, and I don't think it's me, but to add some of their direct on costs, so national insurance costs and things like that, to their link worker payments. But of course, there's still questions about the costs of operations, which are not necessarily met with the link worker funding. A lot of concerns raised around outcomes and measurement, and particularly the expectation in many commissioning cases that link workers and link working organisations employing link workers will be required to use patient activation measure, required to use the PAM, which is just not a particularly good set of questions for many of the organisations that we represent to be talking to people about. And there's a sort of general sense that it's a very, what's happened here again is a sort of very clinical NHS approach, potentially trying to be rolled out into the voluntary sector. Whereas to our mind, the whole point of this should really be the other way around. Potentially in some cases, we heard about people adding in, so Jo adding in PCN link workers into her existing scheme, and that seems to be the model that works best. But in some cases where PCNs haven't engaged well with existing schemes, with local authority funded schemes, for example, we're hearing concerns about how the NHS link worker roles and rollout is impacting on existing schemes in a couple of ways. There's one or two cases where local authorities have said that they don't see the need to recommission their community connecting or social prescribing work because the NHS is now paying for it. But we've also seen more on an individual basis where PCNs have gone out with the NHS rate, then that has attracted people who are working in the VCS as link workers into the NHS roles. So it has a kind of knock-on impact on the workforce. And I'd echo what everybody said about the nature of this role is much more sophisticated than we think, everybody recognises. There's also having rolled this out through this new set of bodies, these primary care networks, which are very small and very local. There's enormous variation in how link workers have been recruited, what they're being paid, what the employing organisation thinks they're for, whether they're embedded in the VCS or whether they are in a GP practice. There's huge kind of variation. So hopefully this now works. Do I have to hand the controls back to you? We would be very interested to hear, oh, brilliant, thank you. We're very interested to hear from you of those 4 issues around the link worker role and the NHS rollout. Just vote for your top 2. In terms of our being able to feed back to NHS England, it's really helpful to get as many voices as possible from the sector of where you think the shoe's pinching. I don't know how the voting works, so I see it's open. Hopefully people are voting away. Do I just go on, Catherine?
Sorry, I was muted there. Yes, so yeah, sorry. Yeah, so people are taking it, are picking currently. So please do.
So I'll go on to the next. So here are the 4 on the link worker. And it'd be great just to get a sense of people's priorities. We're going to report all of these back to the NHS. Don't worry about squeezing things out, but it's really helpful to understand where people think things matter. There's also a set of issues which are wider than the PCN or the link worker role. Obviously, the big one that comes through is where we see increased demand, where we see people being referred to services provided by the sector, whether the funding will follow that. We see some places where there's great examples of cross-sector collaboration and partnership, but others where that's more challenging. Sort of the obvious general finding is that where that's already established, where the NHS, local authorities, other statutory services and the VCS are working together well, then social prescribing fits well into that. Where PCNs aren't part of that collaboration, it doesn't work so well. And in fact, some of the worst examples are where PCNs and CCGs, so that the NHS itself can't cooperate and collaborate with itself, let alone across sectors. There's a sort of wider philosophical question, but it is a real practical and meaningful one as well, about whether we we will sustain the social in social prescribing, whether what the risk here that it becomes medicalized and it becomes sort of checkbox, oh, you've had your social prescription, and the recognition, you know, exactly what Dawn was talking about, that people's needs are incredibly various, and you know, it's not about a menu of 10 things, it's about genuine conversation. That real sense that we're trying to open people's opportunities up could get lost. There are some examples where we've heard about PCNs seeing the opportunity to fund existing posts, so things like receptionists or phlebotomists, you know, and or so arts and health practitioners or health coaches, and saying, oh great, we can use this link worker money to fund those. And so the risk there is that that really doesn't open up the potential of social prescribing. It sort of makes it narrower and more medical. And there's a whole raft of issues around inequality. So that's for individuals who are excluded, who may not already be accessing services, or who we as services, whether that's statutory or the voluntary sector, are not so good at reaching. But also poorer communities where we know that there are fewer organised social activities, that there is less going on to refer to people, and where many of the kind of formal voluntary sector things like advice or like you know, CVSs and volunteering bureaus, that's the places where the axe has fallen hardest. And so the kind of infrastructure in those poorer communities where health inequalities are highest and where the need is greatest has fallen away over the last kind of 10 years. So real issues around how social prescribing, you can't stop that up with social prescribing. There's a set of important things that need to happen around poverty. And one of the kind of concerns is the NHS's model of social prescribing in the Universal Personalised Care Guidance talks about linking people to voluntary and community sector activities, which is great, but it doesn't talk about linking people to benefits advice or to Job Centre Plus or to their housing provider. And for many of the people that we work with who are most in need of these sorts of support, they've got very immediate practical needs that also need to be addressed, as well as social needs. So again, I'll open another poll on those 4 things: funding for the sector, collaboration, the model, and tackling inequality. What to you are the 2 most important ones? And I think I'm probably wildly out of time.
I think as well. I mean, a lot of people, we've still got sort of 86 people joined in.
So I can give a kind of headline of what we've heard. I'll try and be quick about that. I think one headline is there was a concern that PCNs would just go ahead and do this without us, but generally there's some involvement, there's some engagement. It's also positive that although people have been very concerned that they'll get overwhelmed with a flood of new demand, we're not seeing that. People aren't telling us that has happened. People are saying, yes, there's more referrals or there's more people. I think the places that are overwhelmed are places that are already overwhelmed. So it's specialist services, things like citizen advice or legal aid, which are really important for many people, particularly in poorer communities that were already struggling. What we're also hearing is that people are finding solutions. People are making things work. And I think I said already that we're seeing that most creativity where the relationships are really strong. We're also seeing things work better without question where link workers are embedded within the VCSE. So where link workers are part of a voluntary sector ecosystem, it's much, much easier for them to do their work than if they're sitting in a GP practice. But also their manager understands what it is, their sense of what they're trying to do is shared with people around them. So that just in general seems to be a much better principle than plonking someone in a GP practice. But you know, we've raised all those issues. It could clearly still be working better. And I think these kind of what we've heard, I didn't want to kind of preempt the poll, but I think what we've heard quite strongly, these issues around measurement, around funding, around inequalities feel like they're big issues for the sector. So that's the end of my presentation.
Thank you so much. I think that's, I mean, I'm conscious that we are sort of over time, but everyone still appears to be joining in. So if you want to pass back over to me, Dan, on the presenter mode. Perfect. So we have had a whole range of different questions. I'm just thinking through what is the sort of we've had quite a few people talking about specific examples of how we've catered for either people with learning disabilities and autism, or perhaps people who are deaf and might need BSL or other support. I wonder if any presenters have any specific advice on that. And do feel free to chip in.
It's Jo here from Together Co. We tend to work closely with other partners, so we don't get that many people coming through with learning disabilities, for example, because we have several very strong organisations in the city who are providing quite in-depth support. Where we have worked with them in the past is for example, we have BSL interpreters as required, and we work with local deaf organisations to kind of reach out into that community as well. We'd be doing more of that now that we're open to referrals beyond simply primary care. I think we'll see more of all of those kinds of referrals now we're open to refer, from wider than just from the GP surgeries. Thanks.
Fantastic. Okay, I'm just looking at some of our other questions. I suppose it'd be helpful for me to know if there was sort of one key message you would give to people on the chat at the moment about how they could best make social prescribing inclusive. What would it be, and whether any of you has a sort of a burning top piece of learning you'd want to share?
I'm happy to mention our approach on that as well. It's Jo again. I think that this is really classic voluntary sector and community development ethos, which is listening to the people that you're working with, and making it very making your service, designing your service in a way that's user centered, involving individuals in the way that it's developed, and in particular if we're working with specific groups, to make sure that that's kind of tested and developed with individuals as well as with partner organisations. And I think that approach tends to be quite natural within a lot of voluntary sector organisations, and certainly that's the way we've tried to approach our work, and that's the way that, and we have a little bit on this in our training that we offer out to others as well. Be interested in what others have others' views.
Hi, it's Dawn. I think my key message is around getting involved with the network, so the Young People Social Prescribing Network, so that we're able to communicate with people who are doing this work, and that they're able to get involved with discussions and share their learning, so that all the work that's going on, because it's such a new area, this specific young people's part of the work, that we can really capture any learning, any development, help you get your young people social prescribing services set up effectively, so that you can learn from the work that's been done already. So that's the big one for me, is really want to get you signed up to that network.
Hi, it's Rebecca at Live Well Wakefield. For me, it's just making it as open and easy as possible for people to access. I personally believe that restricting it to primary care only or certain organisations means that you're automatically excluding people that don't engage with services. So from my point of view, it would be opening up the referrals and making it as easy as possible for people to refer in multiple ways.
I mean, I think I'd agree with what everyone said. I think, well, one thing that people have already said but that's come through strongly from the conversations we've had so far is working with and through the organisations and community groups that already have links and trusted relationships with people. So, working through groups that are already in, for example, South Asian communities, or that already got connections into homeless communities, so that you're actually you're working through existing channels rather than trying to create your own. One thing that we have heard a few people experimenting with is getting personal health budgets, and obviously for some people in very disadvantaged circumstances, that they will have access to a personal health budget. So actually getting personal health budgets to pay for things like interpretation, to pay for some of that additional support. And we think in the work that we're doing, we want to look at whether some of those kind of ways that money follows the individual with a social prescription in the same way that it follows people with a medical prescription might be helpful for overcoming some of those barriers.
Thank you so much. I am really conscious of our time and thank you so much for everyone for staying with us. I've included a couple of links for some further information, including signposting to National Voice's upcoming webinar on social prescribing. So I definitely would recommend checking out these links. But I really just wanted to say a huge thank you to everybody for joining us today. You know, it's interesting times at the moment, and thank you all for your questions. We'll be collating some of those questions today. We'll be putting a recording of today's session up online, and we'll be collecting all of this information from the polls and from your Q&As, and we'll be feeding that back in as part of our work at the Health and Wellbeing Alliance. So a massive, massive thank you to all of our speakers today, and for all of you for joining us. It's really great to have had you all here today.
Thank you.
Thank you.
Thank you.
Thank you.
Bye.
Bye all.
Bye.